Hi everyone, my name's Merryn. I'm an endocrinologist and general physician.
Hello, my name's Laura. I'm a clinical nurse specialist and credentialed diabetes educator.
Welcome to Your Health Now. So today Laura and I thought we'd have a chat about a topic that is quite interesting and very relevant, I think, to a lot of women.
Oh, absolutely.
I think all of us know someone with this condition. And the condition we're going to be talking about is polycystic ovarian syndrome, which you may well hear called PCOS or PCOS. I personally have an issue with the name because I think that it doesn't quite explain exactly what the condition is all about. And a lot of women don't have very cystic ovaries. So that term polycystic ovaries can sometimes be quite confusing for people.
Or maybe misleading.
Absolutely, that's right, yeah. So we're going to have a little bit of a discussion around what polycystic ovarian syndrome is and some of the clues that might let you know that you or someone you know has it, and then how we diagnose it, and then some of the treatment options as well, and what that means for you long term as well, or for your friend or loved one long term as well. So maybe we'll just start with how you know you've got it, or maybe some of the clues to polycystic ovarian syndrome. So Laura, when you think of polycystic ovarian syndrome, what are those kind of clues that you think about in women?
So one of the most common clues can be, hair on the face or hair in your body. It can be hair on your nipples or hair on your stomach. Acne is another big indicator, especially as an adult.
Yep, and we've got to be careful with that word too, that word acne, because in medical terminology, acne really just means pimples. But I think when we say the word acne, a lot of people think of, really bad, cystic pimples, but we're talking about a spectrum. So even just a few little pimples on your chin or on your cheeks, or really anywhere at any age. In medical terminology, unfortunately, we call that acne. But really, just think about it as pimples, probably, so that it's a bit more general. Yeah.
And what I think is most interesting too is that, kind of what you said before, is that all of PCOS is on a spectrum.
That's right.
So it's good to have this kind of insight, so you can start to ask those questions to your physician.
Absolutely.
So we discuss hirsutism, or hair on your body or on your face. Another interesting part of it that a lot of women are kind of not quite sure to ask about, but it can be hair loss on your head. So hair thinning, either at your temples or on your scalp in general.
That's right.
So this can be another good clue. Something else, and correct me if I'm wrong, but irregular periods.
Yeah, and this is a really interesting part of the syndrome, because you can have regular periods but not be ovulating or releasing an egg every time. And so women with regular periods who have polycystic ovarian syndrome are actually quite tricky to diagnose, Laura, because they're having the regular periods. Women who have irregular periods are a little bit more obvious, when it comes to diagnosis. But certainly sometimes that's the first sign ever of polycystic ovarian syndrome, is an irregular cycle. And that could be literally just missing a period here and there, so that instead of a period every 28 to, say, 32 days, maybe someone's having a period every 50 to 60 days, or it could be quite a long interval between periods, and some people might not be having them. Some people may be having one or two a year, but certainly menstrual disturbance is one of the key characteristics of the condition. Yeah, that's right. So we talked about it being a spectrum, and in medicine, whenever a condition has a spectrum of presentation or a spectrum of symptoms and signs, there's going to be a clinical criteria for diagnosis. So if ever you see that there's a clinical criteria, so a series of different points that need to be met for the diagnosis, then you know that the condition is actually going to be a spectrum. So there's going to be women at one end of the spectrum with one or more maybe mild or less obvious manifestations of the condition, and then there's going to be women at the far end of the spectrum who really are the kind of textbook or classic historical clinical presentation, if you like. And I think this has been one of the biggest problems in diagnosing the condition, is that historically people have thought of polycystic ovarian syndrome as being at the upper end of the spectrum. And we used to call that Stein-Leventhal syndrome. And that really was a more severe form of the condition. So those women had very, very severe menstrual disturbance, sometimes no periods at all. They had severe infertility. They had quite a lot of pimples and hairiness. You may have seen the bearded ladies in the circus and those kind of things. Some of those women actually had polycystic ovarian syndrome. And they also had a very high risk of endometrial cancer as well. And so they really are at the upper end of the spectrum. But there's women right down at the other end of the spectrum, and they may be slim women. They may have, as I said, those regular periods, but they're not necessarily ovulating every time. They may have no pimples, no hairiness. The other aspect of the condition is insulin resistance. And again, that's a spectrum. So some women have quite a mild form of that condition. Other people have a severe form or even progress to type 2 diabetes. And so remember that the insulin resistance we've talked about in previous videos, but just to recap here, the pancreas is the organ in the upper abdomen that makes insulin among other hormones. And insulin is the truck, what I call the truck transporter for glucose or sugar into cells for energy. And if you've got insulin resistance, there's actually a form of blockade, if you like. And again, I'm just simplifying this. There's a form of blockade at the cell, and so when the insulin comes along with the glucose or the sugar, it finds it difficult to get that into the cell. And one of the body's responses to that is to make more insulin to try and overcome that block. And so that's a very big part of polycystic ovarian syndrome for a lot of women. And again, it's a spectrum.
So I have two questions for you. So my first question is, you talked about this kind of extreme or the most noticeable version, I guess, of PCOS. Yeah. And then on the spectrum, we have women on this other end. Yeah. Because of this variance and because of the nuance in it, about how many women do you think go undiagnosed? Or the percentage?
A lot of women. I couldn't give you a percentage, Laura.
I think I've read somewhere up to 70%.
I think a lot of women go undiagnosed. Now, this is improving, so some of those statistics may be
older.
Yeah, a bit older now, but certainly our family care doctors, now our primary care doctors, are much more aware of the condition. And I think as women as well, we're a lot more aware of the condition. But because it is a spectrum and it does have a criteria for diagnosis, many doctors are not well aware of the criteria. The other thing that's confusing is that there are multiple different criteria across different populations. So there's an American criteria, there's a European criteria, there's a Rotterdam criteria, an international criteria. But really what they all have in common is menstrual disturbance of some form. So that's the first criteria. The second is what we call hyperandrogenism, and that's where people either have more testosterone-like substances in their body than they otherwise should, or they're more sensitive to the normal levels of testosterone-like substances in their body. So we can do a blood test and see sometimes higher levels. We may see higher levels of testosterone, but more commonly androstenedione or DHEAS. Or we may see completely normal levels, but someone may have quite a lot of acne and hairiness or hirsutism, and that tells us that they've got those sensitive receptors. So they're more sensitive to normal levels of androgen. That's the second thing. The third point in the criteria is exclusion of all what we call secondary causes. So there are some conditions that mimic polycystic ovarian syndrome, and they're very important to diagnose, and some of these are quite uncommon, like Cushing's syndrome or congenital adrenal hyperplasia, which is an inherited condition, but these things need to be thought about and they need to be excluded. And then as a kind of a nice to have but not required for diagnosis is the ovarian appearance on ultrasound. And again, we've got this criteria that I think are very unhelpful, because it's a criteria really for the severe end of the spectrum, and it's a Rotterdam criteria, and it actually has a certain number of follicles or cysts that you have to see on the ovary. They have to be a certain size. They often have to be in a certain distribution. And for a lot of women, many of us have been on the pill or some sort of hormonal therapy, often from a young age. And all of these hormonal therapies will decrease the number of cysts and treat the condition to a certain extent. And so having an ultrasound, if you've been on the pill or any hormonal therapy, can be very unhelpful. And if you have an ultrasound report that says no evidence of polycystic ovarian syndrome, then unfortunately previously that has been misinterpreted as meaning the person doesn't have the condition, when in actual fact you can have the condition and have no cysts at all on your ovaries, or very few. And so we're very, very careful about that, and not including that as a must-have in the criteria now.
And then my second question for you, that a lot of my patients ask as well, but I'm really interested to hear how you would articulate it, is now we know what PCOS is. We know how it may be diagnosed. We know that it's a spectrum. Why is it important to know if you have it? So if you have all this, what's the importance of treating it?
Yeah, and I might just add too there that we're still really trying to work out exactly what PCOS is. So
that's interesting.
So we know that that it is a state of hyperandrogenism in the ovaries. So we know that the ovaries have this abnormal or variation, if you like. I don't like the word abnormal. Have a variation in the way they handle androgens or testosterone-like substances, and that's really the crux of the whole condition. But then there are all these other aspects to the condition, like the insulin resistance, an inability to lose weight, quickly gain weight, high cholesterol and associated lipids, a risk of diabetes, and particularly diabetes in pregnancy, a risk of endometrial cancer that's higher than the general population. And perhaps a risk of cardiovascular events down the track, like heart attacks and strokes, but we're not really sure about that. So this question of what is polycystic ovarian syndrome, I think we're still trying to answer. We know the ovaries are a very big part of it, but they're not the whole answer to the question. So I think that's something where we're going to be watching this space and probably updating you as new information comes along. And then the second question, so why is this important? Well, first of all, for women, fertility obviously is a very big part of our lives early on. And it can mean that it's harder for women to get pregnant, and that is because women with polycystic ovarian syndrome may not be ovulating or releasing eggs regularly, and some women do need assisted fertility, not necessarily in vitro fertilization or IVF, but often some other therapies to help them, and we'll talk about that soon. So fertility is a very big issue, and alongside of that really is this sense that we need to protect the endometrium, or the lining of the uterus, because if we're not turning that lining over regularly, and we've got a lot of estrogen and not so much progesterone in our bodies with polycystic ovarian syndrome, then that can theoretically increase our risk of uterine cancer. And so we need to be very careful that we're protecting the lining. So they're two things. The metabolic side of things, so the insulin resistance, the issues around weight, you can have sleep apnea, you can have that higher risk of diabetes, a higher risk of down the track, we think maybe heart attacks and strokes and things like that. So they're all very important aspects to the condition. Yeah.
That's fantastic. So what would you recommend if someone's listening, if they themselves or someone that they know might have some of these symptoms?
Yeah.
What would be their next step?
So at the end of this session, you'll find that we've attached a PDF, and in that I've listed the criteria, so you can easily take that to your primary healthcare practitioner, or you can give that to your friends or family members who you're worried about, and perhaps ask them to take that with them. That will be a really good start in that their healthcare practitioners can then have a think about whether or not they might meet the criteria and what they might need to do then to have a look into it. So certainly seeing your primary healthcare practitioner, that first point of call, whether that's your, in Australia we call them general practitioners or local doctors or family doctors, or it might be a nurse practitioner or a healthcare worker. So whoever is your first point of call, taking that information to them may well be a good first step. And then they can look that condition up and see what tests might be required, because we do a series of blood tests and assessments, examinations and things. So that would be very worthwhile if they're thinking about whether or not they have the condition. Yeah.
Fantastic. Well, thank you so much for that, Merryn. That's very interesting. And do have a look at the PDF below. And thank you again for watching our video at Your Health Now.
So join us in our next video when we talk about the possible treatments for polycystic ovarian syndrome. We'll see you there.